age up through age 30. And we have a variety of programs. We have a school for ages 13 to 18. We have another campus called Life 101, which is a young adult employability program, ages 18 and over. We also have Club Hub, which is a social club that meets 3 nights a week and 1 weekend day a month, also ages 18 and over. And finally, we have another campus called Aspire Accessories, again, ages 18 and up. Our members there are called artisans, and they create magnificent items that are sold online and at markets. We really cross the spectrum in those young adolescents up through age 30 who all have neurological differences. And we always are careful to say we're not a therapeutic school or program, as long as the adolescent, teen, or young adult doesn't have behaviors where they could potentially harm others or themselves, we might be a great fit. And thank you all so much. I'm happy to be here today. Thank you.
Thanks, Julie. Brooke, I see your comment. You have 83 locations nationwide. So yeah, if you're not even in Houston, you might still have one near you. Thanks for sharing that.
Yeah.
So I'm Alexandra Roark with the Houston Neuroscience Brain Center. This is Dr. Ron Swatzyna, the director of our center. We provide EEGs that look for neurological causes for symptoms. We provide brain maps as well, and then we use those EEGs and brain maps to come up with a treatment plan that can include therapy, neurofeedback, photobiomodulation. We refer and work with doctors, functional med doctors, psychiatrists. Thank you. And so we wanted to present today because we feel like this topic is really important, and we will get into that a little bit. But before we get started, I just want to ask that everyone make sure that you're on mute because we will be recording. If you have any questions, please put them in the chat. We will have a lot of time for questions and discussions at the end. And at that time, we'll look at the questions in the chat, or if you want to feel free and chime in during the question time, we can do that too. So with that being said, I'm going to start sharing the screen. There. And Brooke, if you could just keep watching to see if anyone pops in, that would be helpful. Okay. So today I'm going to be presenting on how to recognize signs that your child may be psychologically struggling. And so as I was saying earlier, Dr. Ron sent me this article, and it was saying that 3 Texas children's hospitals have seen an 800% increase in emergency room visits from kids and teens with severe mental illness, which is huge. So before the pandemic, the ERs were usually treating 50 to 100 children every month. And now the average is 400 to 450 patients a month. So, you know, let's look at the signs to see, okay, is my child silently struggling? Like, what's going on? So maybe you can catch things before they get that severe. And so the first thing that we're going to be looking at is the emotional and behavior signs. And so this could look like a loss of joy. Maybe your typically happy kid is no longer smiling as much as they typically do, or, you know, being their usual happy self. You might notice an increase in tantrums, a loss of interest in activities, excessive worry, maybe, you know, whenever it's time to go to school or to an event, the child that typically runs into the room and doesn't have an issue is staying by your side, seems hesitant to go somewhere. With the littles, you might be noticing regressive behavior. Maybe your child is starting to suck their thumb again or engage in baby talk. There could be inattention and restlessness. This is a really important one to notice because oftentimes ADHD can be misdiagnosed because there's just underlying trauma or other mental health issues that appear to be ADHD. Because what happens whenever your child is experiencing anxiety or depression, there's these physiological symptoms like this energy that builds up in our bodies. And fidgeting is that way to let it loose. They're not feeling comfortable, they're feeling dysregulated, and then that's their bodies showing that. If we look at physical signs, this can look like disruptions in sleep. Maybe, in the past they have a history of sleeping well, and then all of a sudden they're not wanting to go to bed at night. They're having trouble going to sleep. There's nightmares or waking up in the middle of the night. And then in the mornings, they're having trouble getting out of bed. Before, they could pop out of bed and feel fine and awake, but all of a sudden they're, you know, spending more time in the bed in the morning. And if you think about it, if you're anxious or depressed, your motivation levels are lower. You don't have the energy levels to go up and go about your day as usual because anxiety and depression can also impact your sleep. So I would look out for that. There's also the possibility for changes in appetite. And so this can look like eating more than usual, maybe reaching more for comfort foods more, because in those cases, your kid could be trying to seek some dopamine levels. Whenever we eat those foods that have a lot of sugar, it does give us a dopamine hit and can make us feel better just temporarily. Or on the other side of the spectrum, they might be eating less. So whenever we're really anxious or depressed, the physiological outcomes from that can impact our digestion system. And you might feel a little like icky in your tummy and you don't have the appetite anymore. You're not thinking about food, or maybe they don't even have the motivation to go and get food if they're feeling really depressed. And so if this has been going on for a while, maybe all of a sudden you notice that there's weight changes. Going back to, all the stomach issues that can come up. Maybe your child is expressing physical complaints, whether that could be headaches, backaches because of the muscle tension that's being held subconsciously, stomach issues that can turn into ulcers, or the nauseous like nervousness. And so this would be complaints that don't seem to have a reason. They're complaining, you're like, okay, well, you're not sick, you don't have the flu, you don't have COVID, and so then it seems like the only cause could be psychological reasons. And then the last one here, I have appearance and dress. And so this might be something you notice more with teens. So this could look like if you have a teenager and maybe they really, put a lot of energy into how they dress with like makeup and doing their hair, dressing a certain way, and then all of a sudden they aren't wearing their makeup or putting as much effort into it, and that could be from their lack of energy from the depression or anxiety, and or maybe their appearance and dress is just changing completely. If you think about it, if there's something going on in their life that's causing them to not feel well. I mean, sometimes appearance and dress is the only thing that they can change if they can't change their situation. And so that can motivate them to want to change their style. When we think of school and social signs, you might notice a decrease in performance. Thinking about what we were talking about earlier, the motivation levels in these kids and teens are low. They're spending so much of their energy and their time having to fight off these negative thoughts or excessive worries, and not to mention like all the physiological components that come along with that sometimes we don't think about. Like whenever we're mentally dysregulated, it's going to impact our bodies too, where our muscles are going to be tense, Our digestion is going to stop, and that's going to have an impact on our gut, which then impacts how we feel. And if we're not feeling well, then we're not going to have the energy to perform as we normally do. I tell my clients that, they have a window of tolerance, like a threshold of tolerance. With if you're getting good sleep, if you're eating foods that give you like nutritional value, if you're feeling good, then you're going to be able to tolerate a lot of stuff, like all the things that life hits you before you explode. But if you're not feeling well, if you haven't gotten enough sleep, if you're dealing with low self-esteem, or negative thoughts, then your tolerance for things is going to be so much lower that whenever life is, throwing those curveballs at you, you're not going to have as much energy to take those on. So this can, lead us to our next point of social relationship issues. So you might be getting reports from the teacher that your kid is picking fights or getting into more fights, and it just might be that they can't tolerate certain aspects in their social relationships anymore. If you think about kids and how they pick at each other, that kind of stuff, they might be easier to snap at people around them. Yeah, or they could be getting bullied. So there's that factor too. On the other side, they might be withdrawn, isolating themselves, not participating in recess or wanting to participate in PE, not hanging out with their friends, might not be as exciting or as much of an interest to them. They might not even want to go to school. Before maybe they were okay with it, and then out of nowhere, they're not wanting to go anymore. And that could also be a sign of bullying too. They might be more uncooperative as usual if you're thinking of that threshold of tolerance. And then with social isolation, they might not be wanting to go to birthday parties or social events that they typically would want to go to. So, common disorders in kids. I just briefly wanted to go over this stuff and clarify some things. In my research for this presentation, I found that there's like 6 common disorders in kids, with the top 2 being depression and anxiety. So depression would be that low mood and not wanting to do things. The symptoms are impacting them at home and school. This could be.
Boys present differently than girls.
Yeah, and then like there's another factor too of how boys and girls present differently, of how girls will be a little bit more reserved with their symptoms compared to boys. With anxiety, that would be excessive worries for up to like 6 months, according to the DSM. Eating disorders, that could be restrictive behaviors, overeating, binging, and purging, which eating disorders are actually the deadliest mental health diagnosis out there. With OCD, I just wanted to highlight that, there can be this like stereotype around OCD that it's just, oh, I like things clean and tidy. I'm so OCD, but in reality, OCD can look differently in kids, where it could look like excessive hand washing is a common one, where they're washing their hands so often throughout the day that their hands might be rubbed red and raw. Or it could look like counting. So they might count the syllables or letters of, the teacher that's talking. They might want to count things around them, and they have this strong urge to do it where they can't stop. It's almost like this feeling that something bad's going to happen. And there's trichotillomania, where that's hair pulling and skin picking, and behavioral problems. And then bipolar disorder is the last one on the list, which is diagnosable in late teens. And then I just wanted to clarify with bipolar disorder, this one can stereotypically be thought of, okay, if my teen is happy one moment and then just explodes the next, and then it's happy again, and then it's crying, the quick back and forth means, oh, they're bipolar. But really bipolar, there's 2 types, and it would include a depressive episode and then a manic episode. And then the other type, there's a depressive and a hypomanic episode. So I just wanted to highlight that. But When it comes to talking about suicide and self-harm with your child, let's say that, they come to you and they express that they are having thoughts that they want to die or that they want to hurt themselves, it can be a gut reaction to say things like, oh, don't think this way. Why are you saying that? You shouldn't feel that way. But whenever you're doing that, um, it can send signals to the kid that this isn't a safe conversation for them to have with you. They might feel shame from that, and then they'll shut down and think, okay, this is not a topic I can talk about with mom or dad. And so it's really important not to shame, even though you're going to have that like physiological fear response, because of course you don't want them to think that way, or you don't want them to feel that way. You want for kids to be happy. But the best way to handle that situation is just to be loving, empathetic, and validate their emotions. Validating doesn't mean you have to agree, but it's just a way of saying, like, I hear you. I hear that you're really upset about that situation. If that happened to me at school too, like I would feel very upset too. It's just allowing them to feel heard, because on the other end, if parents are invalidating their feelings or like, oh, well, you shouldn't be feeling that way, then that's just going to shut down the conversation and they're not going to feel like it's a safe space. And then, as you validate their feelings and, show them your love, you can ask them, if they're saying that they want to die, you could say, well, do you have a plan? How much have you thought about it? And this can be scary for some people because it can be a common thought out there that if you talk about the suicide, if you ask questions, if you ask if they have a plan, then that's like planting seeds and it's more likely to make them to do it. But research actually shows it's the opposite. It gives them a safe place to talk about it, because the fact that they're even bringing it to you is a good sign. It's a sign that they are asking for help, and that's a really good sign. So, by asking if they have a plan, that can also let you know of how far have they really thought about it. Because sometimes with kids, they just don't have the language to express how they really feel. And our brains can be so mean to us, and they can come up with these really horrible, intrusive thoughts where if we have a really rough situation, or if we're getting bullied, our brain is just like, oh, I just want to die. But so, what I ask is, okay, do you really want to die, or do you want the situation to die, to be gone? And asking it that way can help, reframe to them. And then you could communicate to them, okay, well, let's think of some ways that whenever we're really upset, of how we can communicate how we feel instead of like listening to intrusive thoughts. And then also asking, depending on the age, if they're really young, like, what does death mean to you? Like you said, you just want to die. What does dying mean to you? And then that can be a conversation of, even explaining to them what death actually means. And so on here, I have the ratio. It's important to think about your positive to critical interactions. And I got this ratio from the Gottman Institute, which specializes in couples, but I thought that this was really relevant to families as well. And so what Gottman Institute says is that you should have 5 positive interactions for every 1 critical interaction. So, be thinking of, okay, throughout the day, how many times do me and my child have a positive interaction versus critical? And so then if there are critical actions, you could try to be more mindful to add some positive ones in there too, to really, instill a positive environment in the family. And then lastly on here, I put social media and online activity, because this part I feel is really huge and part of this discussion. Our kids and teens are exposed to so much online. And so many times these kids and teens do not have any kind of restrictions on their mobile devices. And so the things that they are seeing on YouTube and forums and Snapchat, There, TikTok University, Dr. On said, can have topics around suicide and self-harm. And the things that kids have told me that they've seen, and they're like, yeah, my parents have no idea because there's no restriction. It's wild what's out there. And some parents be like, oh, my kid's really mature, they can watch this show. And yes, your kid can be mature for their age, but the science behind brain development really shows that your prefrontal cortex doesn't really kick its full development until you're 12 years old, and then it doesn't stop developing until around 25. So really developmentally, your prefrontal cortex is in charge of critical thinking, decision making, weighing pros and cons. And so it's just their brains aren't in a place yet to digest that information and make sense of it like we can. And then I have peers on here too, because it's also important to monitor what our kids are talking about with their friends. I understand that parents want to respect privacy levels to a certain extent, but I just wanted to really emphasize how the talk around suicide and self-harm can really spread like wildfire. And I wanted Dr. Ron to speak on this from his experience.
Well, I think that is very critical. We know that these children are influenced by so many people outside of them. And if we're not nosy parents, if we're not the ones that can actually take charge of monitoring this, parents think that it's their responsibility to make their kids happy. I said, well, that's not really their job. The job of a parent is to prepare them to be fully functioning, independent adults someday. And so in that process, yes, I think it's good that parents are more overseeing of their children's social media, their online activity, their peer relationships and everything else, because that's your job, is to make sure you can navigate them through those tough times. And these peers and these online activities and social media, when I hear a child say, when I talk to a teen and I say, well, what are your thoughts about getting a driver's license and maybe eventually going to college and moving out? And it's a phenomenal amount of them that are just, they don't want to drive. They don't want to become independent. They're happy with where they are. And when I hear a child say, I can't wait to move out of this house, I look at the parent and I go, so that's really good parenting, because you want them to be ready to leave the nest when they get of a certain age. And that's a good thing. So that's good parenting. Prepare them for how to make those decisions, you want to allow them to fail when they're young, because they need to learn how to navigate the world. And the only way to find that out is to try something and let them fail. But then again, we don't want them to be into that trying to commit suicide. And
tell them about how it'll spread like wildfire, like the cutting and suicide that you've seen.
With the peers and stuff that we've seen. And I used to work in in a psychiatric hospital for 4 years, 3 months in a day, not that I was counting. But it was interesting how when we got a cutter on the unit, on our adolescent unit, all of a sudden we had 3 or 4 find a way to start cutting themselves. It's almost like it's contagious. And you've heard about vocal and motor tics, Tourette's being passed on around among the peers. And the same thing goes with the suicide. So suicide, when one happens in a school, you can count on 2 or 3 more attempts, if not successful attempts, over the next month or so. So it's, these types of activities are very dangerous, and parents got to be riding herd on it. The big problem we have right now is that kids don't want to talk to parents, of course, and there's an extreme shortage of child and adolescent therapists. Of course, we're lucky to have one, but we just want to address that right now.
Yeah, I thought that was important to hear his experience of how it would always spread like wildfire at his units. And then in my time as a therapist too, seeing how the conversations will spread with kids at school too. So it's important to monitor those conversations at all possible. So when to go to the inpatient admission. So if your child is in imminent danger to themselves and others, then that would be the time where you could take them to an inpatient facility to get evaluated. If your child is using threatening statements of like, oh, if you do this, I'm going to kill myself. If you do this, I'm going to cut myself, then this is when you could take them as well. Whenever you take them to an inpatient facility, it's not guaranteed that they're going to get admitted, but they can go through the evaluation process to see if they will or not. But besides that, you know, if you feel like, okay, I'm noticing some of these signs, I think that therapy is going to be a good decision for my kid or teen, then I wanted to talk about what therapy is like, because a lot of times, you know, people don't know what it's like. So what the process would be, you could do a Google search to see therapists near you. I like using psychologytoday.com. On there, you can search for therapists within your area and you can read their bios. You can see if they take insurance or what their rates are, and then that can help you choose who to start with. Therapist shopping is completely normal because it's so important to find a therapist that really clicks with your child. You want them to feel that trust and rapport with the therapist, or otherwise the therapy is not going to work, because therapy is built on that therapeutic bond. And so, you know, it may look like trying out a couple of therapists, and that doesn't mean there's anything wrong with the therapist or with the kid. It's just that, you know, some personalities don't mix. So, you know, you can shop around. Therapists will do consultations, sometimes by phone or in person. So I wanted to clarify the difference between therapy and psychiatry. A psychiatrist would be someone who prescribes medications. This is someone you could take your kid to for an evaluation. They would see if medications are a good fit, and then they would see the psychiatrist every 3 months or 6 months, depending on the medication. Whereas therapists, they don't prescribe medications, and they would see your kid on a weekly or bi-weekly basis to work on their therapy toolkit. As far as therapy, confidentiality and obligation to report. I thought that this would be really important to highlight. As far as confidentiality, when it comes to any therapist, they have whatever is said in the session is to be like remain confidential between the therapist and the client. And so what I tell my parents and my child client in our first session is that I told the child, anything that we talk about in here is going to remain confidential between you and me. There's only 3 exceptions to confidentiality, whereas you say that you're going to hurt yourself, if you're going to hurt someone else, or if someone's hurting you. And hurting can look like different things. But in those cases, I do have to break the confidentiality and tell your parent so that we can make sure that you're safe. And then, you know, I'll go into, you know, there might be some situations where we talk about something in therapy, like a coping skill that would be helpful for your parents to know. And then in those times, we can have conversations on if you'd want to tell your parent, or if you want me to tell, do you want to be there? Do you want to not be there? And then with obligation to report, it is required by therapists that if we do find out that there is abuse happening, then we would have to make a report to CPS. And in those cases, I also include the parents. I don't do anything behind their back. I would tell the parents, you know, my licenses require me to report this. I would like you to be there with me so you can know everything that is said, and you can help me fill it out. Yes, yes. We like to include the children and the teens as well, so that everyone, you know, can know what's going on and not feel like anything is going on behind their back. And then I put this in here, knowing the difference between client goals and parent goals for therapy, because if a child comes to me, the child is the client, not the parents. So parents may come in and they're like, our goals for therapy is I want my kids' grades to go up. I want them to clean their room. I want them to be nicer to their brothers and sisters. But the child might not be there yet with their goals. So, you know, let's say if a therapist was to, you know, follow the parents' goals instead of the kids' goals, then the kids aren't going to like buy into therapy or want to be there if they just feel like, oh, this person is here to just make me do what my parents want to do. So, by starting therapy, will start with building a relationship with the child or teen, building rapport, and that could look like playing board games or just talking about hobbies. And then as rapport is built, that's when kids start opening up. They'll start saying things in therapy that maybe they haven't told other people, or things that they're struggling with because they feel safe with the therapist. And then as we work on the client's goals, often there can be a little trickle down effect where parents' goals are met too. And then at the beginning of therapy, I also start with the basics. It is so important to do an assessment of nutritional intake, sleep, movement, and labs, because if the kids aren't eating food that gives them nutritional value, if they're not eating enough protein, then their brain is not going to be able to support them in their body, especially with the long hours of school. And then with sleep, if they're not getting good quality sleep, if they're staying up on their phones or devices, or if their struggles are impacting their sleep, then that's going to have an effect on everything too, because then the next day their bodies are going to crave food without nutritional value. They're not going to be as likely to move around. And movement is so important because it releases that energy that builds up in our body when we are anxious or depressed, and can release tension. And then it also helps us sleep better at night. And then labs is something that I like to look at too, basic labs. I like to look at folate levels, B12, vitamin D, vitamin B12, because if there is so much connection between abnormal labs and suicide and psychiatric symptoms. And so I want to make sure that there's nothing else physiologically going on that could account for these symptoms. And there's gene mutations like the MTHFR gene that we look at, that's in about 40% of the population, that will impact neurotransmitter chemistry and impact melatonin, which would cause sleep issues. And so as far as interventions, I just wanted to highlight that each therapist will have their own like frameworks and interventions that they use based off of their schooling and training or whatever they click with. And so that can be something that you look for as you shop around for a therapist to see what could be a good fit for your kid. Some of these stand for CBT is cognitive behavioral therapy, EMDR is eye movement desensitization and reprocessing. I'm not EMDR certified. There's DBT, which is dialectical behavior therapy. That's good for kids who are expressing really big emotions. And then there's ACT, which is acceptance and commitment therapy. And then I put polyvagal theory because that's one that I use in there too. But these are things that you could look into. EMDR is great for helping people get through traumatic events. Cognitive behavioral therapy is learning tools and techniques to help us reframe our thoughts and, figure out ways to talk back to our negative thoughts and reframe our thinking. And then I put family therapy and parent consultations on here because those are available as well. If you just wanted to do a consultation with a therapist to say, how things are going on with family dynamics and what you could do to help support your kids and your family. Family therapy is where you would do a therapy session with your kid and siblings and whoever, depending on the situation. And then beyond therapy. So when should medications be considered? I wanted Dr. Ron to talk about this, and then I'll give a little example afterwards.
Well, medications are something that, especially in children and adolescents, are for crisis situations. No doubt about it. I mean, if your child is going through a crisis and is imminent danger to themselves or others, they're probably in need of medication to prevent them from hurting themselves or someone else. We like to use the EEG, the quantitative EEG brain mapping, looking for the causes of these symptoms. And then we can also look for what medication may be matched. And I can have a discussion with the psychiatrist about that. I'm not an MD, so I can't talk to the parents about what medication would be better, but I can always talk to their psychiatrist and make those recommendations based upon what we find. Neurofeedback is a great way to optimize brain function without medications, and it can address a lot of things that medications could never address. We're getting ready to do another presentation on neurofeedback for ADHD, and we'll get more into that as well. Then we've got photobiomodulation, which is a big word that just says we've got some great tools in near infrared light and devices that can actually help reduce inflammation in the brain, help people sleep, improve the microcapillary blood flow. There's a lot of things that has a lot of positive advantages. And then we find that neurofeedback and these other interventions that aren't necessarily there's a lot of kids that aren't really ready for talk therapy. They may be too traumatized. They may be too nonverbal. I had one boy that was with me for about, I guess, 3 months, and I don't think he said 3 words in 3 months, and it was just kind of odd. But I was there, and we went over different things, and he came back to me 2 years later and said, "I helped you more than anybody." I said, "Well, you didn't hardly say anything while you were here." It was just amazing what you can actually get accomplished just by being there and caring. So sometimes we need a method like art therapy or something like that to be in between so that they can break down that resistance to opening up to you. And what's the next one?
Well, I'm going to give an example
Sure.
real quick based off of this. But Dr. Ron was talking to our team the other day about a book that he read. And, what was it? The Caretaker.
Oh, Care of the Soul.
Care of the Soul.
Sir
Thomas More. And so he was telling us, sometimes with our society, anytime that we're feeling sad, we might just automatically want to go and put on a med because we just want it to end. But, it depends on, the type of depression, but, with situational depressions, depending on how it is, I mean, there can be a beauty in working through that depression. And then when you get to the other side, the confidence and esteem and character that is built from getting through that and the skills that you learn can be so valuable on the other side than just putting medication and numbing it and not facing it.
I think Thomas More was talking about the actual fact that depression is basically the foundation for your soul. And we tend to want to stop depression. I do think that's totally wrong. In many cases, we need to process through it because there's several things situationally that can depress us, including somebody's death or, just a multitude of things, but we need to process through it. I think we're doing them a disservice when we stop the depression with an antidepressant, for instance, and especially if they're not in crisis, and we don't teach them how to get through the depression. And art or any sort of talent, 95% of art and literature is based on the very depressed people. 5% is very much in love, but in between, like Taylor Swift, she has this down to a science. She knows that when she wants to write a new song, she just breaks up with her boyfriend and she gets depressed and she writes a new song. So it must work for her. And I think that's one thing that we have to look at is there is a positive side of depression if we can tap into their artistic side or their musical side or whatever. So
right. But and then on the other hand, though, there can be times where medications can be helpful in getting you through that depression. And I had a client who, we tried therapy for a long time and it just wasn't working. The depression was so deep that you don't even have the energy to apply the tools in therapy that you're learning. And so they got on a medication and that got them to the point where they could get out of bed and they could go to school. And tried that for a while, but they still weren't reaching that level quality of life that they longed for, and so I think it was somewhere at that point. So we did neurofeedback sessions, and that on top of everything else was able to get them to the point where they could get up and be happy. They could go to school and enjoy it. And so, you know, every situation is different, but then, you know, your therapist, psychiatrist can, you know, help you decide if that medication is, you know, a good time or not. So, now here we are at questions. So let me make it where I can see everybody. How do I
Stop share.
Thank you. Okay. So someone in the comments said, love that you talk about the nutritional balanced diet and sleep. Yes, that is so, so important. I really appreciate Dr. Ron for really instilling that into me as a therapist of, you know, we need to look at the well-rounded picture. We need to look at the systems. We need to look at the body systems.
Does anybody have a question?
Yeah.
Go ahead and raise your hand and we could try to call on you.
Yeah, you can pop in or write in the chat if you don't want to say that.
Well, we've got a few minutes here. Pam, you walked in late. While people are thinking about questions, you want to go ahead and introduce yourself and Ada?
Yeah, and then Nora, we'll get to your question next.
I'm Pam Esser. I'm with Ada Southern Region, and I was just going to put this.
Oh, Pam, it looks like you accidentally got muted.
Whoops, there. Sorry about that. This morning's been one of those. No, I'm with Ada Southern Region for attention deficit disorders. And it will not let me stay. Let's try it again.
Nothing on my end.
There. I'll just turn the whole thing on. I'm with Ada Southern Region, and we have support groups virtually, and then we have different workshops and events. The presentations for support groups are free, and there's about 4 a month, and then we certainly support this event once a month as well. So in the chat, I'm going to put our list of groups that we have, and then we have a workshop on Saturday for ADHD and comorbidities, helping the family survive. And often we do have CEs as well. So please check us out, use us as a resource, and we're happy to be part of this. Thank you.
Happy to have you, Pam. Okay, Nora, what's your question or comment?
Yeah, so my name is Nora Magnuson Mazzoni. I go by Nora, and I'm at the Magnuson Mazzoni Center in the Woodlands, Texas. And I do a lot of basically memory reconsolidation has been my focus lately, with gaining more resources like accelerated resolution therapy, EMDR, and exploring those for, I'm really on this kick. Okay, I'm nerding out here on this neuroscience, and I'm just going to be honest, and I love it. And so I'm actually looking at applying, I am in the process of applying for getting my PhD in neuroscience. So I'm, yeah, so this is where it's at, like lately, you know, like getting into the neuroscience behind it. So I love that I'm here, and I'm excited to hear what you're sharing. I just find that, what are some, as a professional, this is more of a professional question per se, is that with the neuroscience, I'm looking at a PhD program in behavior and cellular neuroscience. That's kind of what I've been looking at, with really liking the implicit memory for the somatic experiencing with the memory reconsolidation. So I just wanted to know your experience with this, and if, you know, I'm on the right track, because I really feel like there's so much more to explore, so I can better help people who are needing support through their healing process of these trauma memories that I've been focusing on.
Well, I think, if you don't mind, I think that, Nora, you're onto something here. I think we're making a big shift right now in psychology, because we've already been told by the National Institute of Mental Health that the DSM is not a valid instrument. And I think we've got to make that shift to understanding what's causing these psychological symptoms. And we can't just think that the brain is by itself without a body. We've got to look at the whole thing. And I think that's where you're going to find the consolidate, you know, when you're looking at trauma, when you're looking at stress, when you're looking at how memory is consolidated, the neurochemistry nightmare that goes into all of that is just overwhelming. But the more you have an understanding of the systems, I think that's great. PhD in neuroscience would be probably phenomenal. And what I would like to do is invite you to come to our center and shadow me for a day, and we can open you up. I've got the largest neuroscience library, I think, in this whole area. And we're right now putting an index together. So anybody that's any of these high school students that want to come and check out books from our library are more than welcome to. But it's quite extensive because this is where we're actually going. The chemistry, the like the Alexandra was saying, the moving, the sleeping, the nutritional is just all so important nowadays. And I think that we're going to have to look at that. And that's why we're asking every person we see to bring us in a set of labs, that you current labs, so we can take a look at them. I'm actually working on a paper right now where we've got a table built for all the abnormal labs and all the psychiatric presentation of all the abnormal labs, which if we're going to diagnose in this field, we've got to be able to rule out medical etiology. And the easiest way to rule it out is for us to actually basically look at the labs. And so we're going to turn this into a program so all therapists can reference this, because you can't fix abnormal levels or low levels of vitamin D with psychotherapy. You got to get the vitamin D up. You can't fix it with the psychiatric medication. Thyroid issues in children and adolescents, I've found, causing psychosis. You can't fix them with any psychotic. You got to address the thyroid issue. So that's why I've expanded beyond that.
Yeah.
All right.
Yeah, Dusty in the comments, ready to go. It's she said Nora is absolutely amazing, and so are her CEU events. She is a force. So Nora, I saved your information, so I'm going to try to look out for your CEUs. And then in the comments, I also put our website in our email. So if you want to email us, we could talk about like you shadowing, and I see you say, are you hiring? So we can talk to you.
Yeah, I want to learn more. That's where I'm at, is like,
Well, what
yeah,
we love is that you're up in the Woodlands, because we need practitioners in the Woodlands we can refer to. I mean, there's 6 million people in Houston. We don't have to hoard our patients. This is crazy. We need to all work together on it. So
yeah, I'll come and see you guys for sure. I'll email you.
Perfect. Dusty, did you want to add anything?
Yeah, I was just going to add, thanks for reading the comment, but I just wanted to add, I'm so happy this connection was made, Dr. Ron and Nora, because I see some fantastic things happening here in our area. So I'm very excited. Yeah, Nora's amazing.
And I love doing presentations. So Alexandra and I will travel for you guys, you know, because in that common vein of helping to spread the information. So we'd love to do presentations. If you guys get as a group together, we'll be happy to come and do that.
Yeah.
Okay, any more comments? You put all of our contact information in there?
Yeah, I put our contact. Well, while people are still thinking of comments or questions, I want to announce our next topic and date. I believe it's October 18th.
I think it is.
Right?
It is.
Yes, Wednesday, October 18th, 12 to 1. And we are going to be doing our topic on neurofeedback therapy and ADHD. So it's going to be a really, really good, interesting topic.
It's a hot topic. We haven't talked about it in a while. We've got more to add to it. And I think this is going to be something very interesting. Testing. There was a question here about testing.
Does insurance cover testing?
Now, the insurance, the EEG and the quantitative EEG work that we do, insurances most often don't cover it unless unless the person has failed multiple attempts at medications, and the psychiatrist refers for the point of trying to rule out seizure activity. They'll cover the EEG part. As for the neurofeedback, they're covering, and neurofeedback, substance abuse, and traumatic brain injury or acquired brain injury, they're covering now for neurofeedback. So they're in the state of Texas. They also have House Bill 1919 passed in 2009 that states that insurance from Texas cannot exclude neurofeedback as a treatment for neurocognitive rehabilitation. under acquired brain injury. So we're making some progress there. Again, there are some cases that I guarantee medication just won't work for. And whether it's we need to hold up and see what's going on with their body. I found a child the other day, a 6-year-old, had very terrible behavior. He got kicked out of 2 kindergartens for biting kids. And he came up diagnosed with encephalopathy from his EEG from our neurologist. And we sent him to Dr. Melissa Jones, pediatric neurologist in Katy, which is excellent. And she identified that he had toxic levels of Roundup in his brain. And the Roundup was for people spraying it in their backyard to get rid of weeds, but this child couldn't chelate it out automatically. So he was toxic in Roundup. He was Agent Oranged in his backyard. What would have been the course of that kid's treatment and probably incarceration eventually if we hadn't identified what was causing the symptoms? So that's why we do things different here. We don't necessarily start anybody in treatment until we figure out what's causing their symptoms. So
Yeah. Well, someone asked if the presentation, if we have CEU certificates. No, we don't offer CEUs with this. I'm honestly not sure how to get to that level, but
we would have to charge for this, and there's a whole lot of other things, and it's a lot of headache. We started this with Pam and with Julie and with Brooke, with Fusion. Back during the time of pandemic when everybody was locked in, and I felt that there was a lot of need for people to have information. So we just did it as a multiple topic discussion once a month, just for the sake of parents and everybody else. And anybody that registers does get a copy, even if they can't attend. So anybody on the list that wasn't able to attend will get a copy of what we're doing, and we keep those on our website. So
yeah. And then the events are posted on the Fusion website. I try to post them on our Instagram. And then Nora, I do have your email, so I can add you to our newsletter list if you're okay with that, so that when HMBC sends them out. Okay. But yeah, I guess we just have about 1 more minute. Is there any questions I missed? Are there?
somebody joined us way late.
Alexandra, do you feel like it's getting more challenging over time to like kind of navigate that parent-child conflict that can present, given how much kids are using social media and kind of drawn into things that parents don't necessarily know the full extent of?
Yes, I can only imagine how difficult that's got to be, because even if parents did put restrictions on social media, there's probably so many easy ways to see around it. So yeah, I mean, we can't, I guess, have the idea that we're just gonna protect them from everything, but at least putting some like stumbling blocks so it's not super easy. I think it would be good. But that's got to be hard in other ways too, because I mean, I remember being a teenager. Phones came out when I was like 11. I think they weren't that fancy, but I mean, I remember when my parents would try to read my messages, and it just felt like a huge invasion of privacy and the anger I'd feel. And so that's got to be hard for a parent to like want to respect their privacy, but then also feel that need to want to, watch out for them.
And I remember my teenage years, believe it or not, that many years ago, but I had a lot of concussions playing high school football, and they attributed my negative behavior and depression and everything else to just the teen years. And the whole time I was pretty badly brain injured and had nothing, nowhere to go, no assessment, no way to discover this. So if you've had a child that has had a head injury, had a concussion, had a significant bump to the head, and you see a personality change in the next year or so, that might be time to get an evaluation, because it took me 34 years to get all my degrees, and I don't recommend that plan for anybody out there. It's just one of these things we got to consider. There may be a reason for that behavior that's not just going through puberty. Okay.
Yeah. Yeah. Well, thanks for that question, Nikki. It's good seeing you. Thanks for joining. And everyone else, thank you too. We'll be sending out this recording either today or tomorrow. And I was going to say something else and I forgot. But it's really good to see everyone. I appreciate all for joining and hope to see y'all next month.
Thank you.
Thank you so much.
Thanks, guys.
Here, sir.
Thank you.
Thank you.
All right. Bye-bye,
you.
guys. Enjoyed it. And looking forward to meeting you in person.
Yes.